and welcome back to our A to Z of the NHS. We've managed to make it to letter C, even if we might not have finished editing the B's yet, but we're doing the recording nevertheless. So, Andy, welcome back.
We've got 3 C's to discuss today. The first one we're going to do is chest pain, and I think I'm going to talk more about that as a hospital doctor. And then we're also going to do Crohn's disease and celiac, and I think this is more in your territory, so on this occasion I will swap to being the interviewer and you the interviewee.
So, chest pain, that tends to be the thing that I actually see a lot of patients for and then bounce them on to you. Basically, if it's chest pain and I'm concerned, I'm not going to deal with that on the initial case. So what's going to happen when I've seen a patient and I've been worried about chest pain and send them up to you at the hospital?
That's a very good question, and I think you as a GP and you out there as the general public should have a very low threshold for sending patients to the hospital with chest pain, because there are a group of very serious causes which we'll talk about in a minute, but many of those serious causes need treatment that can really only happen in a hospital.
Now, you say having a very low threshold. I think that would be probably something really useful to delve into now, because I hear from lots of patients say they're worried to go to the hospital because of COVID at the moment. What would you say if someone has chest pain?
I understand that we're in a pandemic, and I understand that COVID is bad and it's dominating the press at the moment, but people still have heart attacks, or as we call them, myocardial infarctions, and clots in the lungs that we call pulmonary emboli or PEs, and these are 2 very, very serious conditions, and both often present as chest pain. So if you ever have chest pain, you may have one of those, and they really can only be sorted out in hospital. So I would encourage you to come to the hospital if you can't get to your GP, or if you can get to your GP, you may want an assessment there first. But I think most of the time, people with a rapid onset of bad chest pain should come directly to the hospital.
And in all ways, we will look after you when you come to the hospital. We're streamlining patients who we think might have coronavirus and all those other patients who need our care. It's a safe environment still.
So back to your question of what happens. Well, patients with chest pain are prioritised, so that's the first thing. You don't sit in the queue in the waiting area. As soon as we hear those 2 words that we're all slightly worried about, chest and pain together, you get put in an accelerated system. You have an ECG, an electric recording of the heart, very quickly, and depending on what that shows, you'll either be put into the resuscitation area, which is where we put the sickest patients, or what's called majors, which is an area where people have major medical problems.
So we've got, you know, the approach when the patient's in, we know where they're going to go, but what are we going to do for that patient who's, you know, gripping their chest and they feel like they've got a rhinoceros sat on it?
Well, having had a quick look at the ECG, which will tell you fairly quickly whether the patient's having a heart attack or not, you would then proceed to doing a couple of things. First of all, you'd almost certainly put some oxygen on them, and you would put a needle in a vein in the arm. We call this a venflon, and this is because we may need it later on to give you drugs with. So that's the very first thing that would happen. One of the things that we're looking for is a section of the ECG complex. Probably everybody's seen it on the television when it does that. And these blips have stages, about 5 stages. And one stage is called the ST segment. And if that is raised, that is highly suggestive of a heart attack, a myocardial infarction. There are other causes.
And with what you were saying on the ECG, those changes, there's some are, as medics, we're very good at giving sort of nice touchstone names. And one of the names that I have heard with regard to ECGs, when we have these very large raised portions, when someone's having an MI, they can be called tombstones. And I think that gives an idea of how severe these things can be and why we desperately want to see patients with chest pain so that we can work out all the other causes and hopefully reassure them it's not a heart attack.
Yeah, absolutely. I have heard that phrase. I must admit I don't use it myself, and I wouldn't recommend us using it. I think it's a bit of a Grey's Anatomy type phrase. Even if it is used in America, it doesn't mean that we have to. I'll tell you a little bit about what happens next after that initial assessment. The junior doctor who sees you, or sometimes maybe a nurse, a specialist cardiac nurse, would take a history. That means ask questions and then examine you, because people don't just have heart attacks. That's not the only cause of chest pain. I've got on my crib sheet here at least 20 causes, and we go through history and examination to find out the cause of the pain. And as well as the ECG, we normally do 2 other tests, including a chest x-ray and one of my favourite tests that we talked about before, which was arterial blood gases. You'll remember them, James, won't you?
Yes, I remember the sort of vampiric look in your eyes as you thought back to doing them.
So what I thought I might do now is talk about how we decide the cause of the chest pain. And in broad terms, there's 4 groups. There's the big group that everybody's heard about, that people tend to focus on, which are the cardiac or heart causes. And of those, there's 4 that we see on a reasonably regular basis. Heart attacks or myocardial infarction, something called a dissection of the aorta, and then something called pericarditis and myocarditis. Now, I'm not going to go through all of these today, but I would like to talk about the heart attacks and this second thing, a dissection, if that's all right.
Because from my memory of medical school with that, we can actually sometimes get hints of what might be going on with the patient with the way they describe the pain, haven't they?
Absolutely, absolutely. So when somebody's having a heart attack, we actually use the phrase myocardial infarction, and we lump that with 2 other things, stable angina and unstable angina, into a group phrase called acute coronary syndrome, or ACS. And the clue to that is the type of pain. It's often described as a heavy central chest pain radiating down the left arm, whereas the pain of a dissecting aortic aneurysm is a more severe pain and usually radiates through into the back.
I've heard it described as a tearing sensation as opposed to that heavy weight of the myocardial infarction.
It is described as that, but actually these words are not terribly helpful in clinical practice, because what's tearing to you is heavy to me, and we have different pain thresholds. So I think it's more where the pain is. And I quite often ask the patient, how would you grade the pain between 0 and 10, when 10 is having a baby and 1 is a mild headache, and sometimes that helps you decide how bad a pain is or not. So they are a couple of the important cardiac causes of chest pain. The heart attacks, the ACS, are diagnosed with an ECG and with a blood test called TROP-T. To diagnose a dissecting aneurysm, you actually need a big test, you actually need a CT scan. And that's another reason why I think patients with chest pain should go to a big hospital, because they will have a CT scanner there.
So, for example, in Warwick Hospital, where I've spent a lot of the time, we've got all that same kit, but we go to different departments. You guys are really lucky. You've actually got a CT scanner in the A&E department, separated by 1 door from majors.
Absolutely. We're very lucky in our hospital in Coventry. It was a purpose-built hospital that opened in 2006, and actually there is, as you say, a CT within the emergency department, so it means patients can go from the ambulance through resus and into the CT scanner. So we could make a diagnosis of an aortic dissection in half an hour, for example, whereas another hospital that would take a few hours. I'd like now to talk about the respiratory causes of chest pain. There's quite a few. The main ones that I'd like to focus on today are pulmonary embolus and pneumothorax. And the reason I've chosen those 2 is because they're important, they're dangerous, they can kill you, and there are very effective treatments. A pulmonary embolus is a clot in the lungs. They're relatively common. There are risk factors like being a woman, like being overweight, like being on the pill, but anybody can have a pulmonary embolus.
Now, I think it's important to say we haven't checked scripts. We knew what we were talking about at this point. You say that they're relatively common. This week, I have had a lady who has been overweight, who'd come back from a flight and has a pulmonary embolism. Just this week.
Isn't that astonishing? And I promise you, viewers, that is not a setup. My story for pulmonary embolus is a rather sad one, actually. It was a young woman I looked after 15 plus years ago. She was very overweight. She had young children. and she had a fracture. She fractured her ankle. Just walking, she tripped and fractured her ankle. And about 10 days later, she had a rapid onset of chest pain, came up to the hospital, and unfortunately she had what's called a saddle embolus. That is when somebody has a huge blood clot in both of the main pulmonary arteries.
And we call it a saddle emboli because when we put the patient in the CT scanner, it looks like a saddle sitting across there when we slice it in half with the radiogram. With the radiogram? What is this, 1700? when we slice it in half with the CT scanner.
The patient was discussed with me. It was about 8 o'clock at night when the registrar clicked that it might be a pulmonary embolus, and I said get a CT scan immediately, and that happened, but unfortunately we were too late and the patient was transferred to ITU and died about 2 o'clock in the morning. So that was a very, very sad day for me because I was the consultant responsible for her. I was in charge of the take. But bad things happen in medicine sometimes.
It's actually interesting what we were saying about patients coming in, and we use the history to get a lot of the diagnosis, and we can confirm in other ways. With patients who've got coronavirus at the moment, they sound, the things that they describe, sound sometimes like a pulmonary emboli. And when we do the tests, looking at their SATs, the ABGs, they appear to have a pulmonary emboli, but they haven't had them when we've put them in the CT scanner. One of the things that we have found is that these patients are getting microemboli. So we've gone from one extreme, the saddle embolus, this colossal clot blocking the big arteries, to these microemboli blocking the small arteries, which is why we are evolving with our knowledge of COVID even at the moment.
But I think it's also right in saying that COVID is a great pretender and can present as almost anything. So it can, for example, lead to myocarditis, that can lead to chest pain, and as you say, it can lead to a pulmonary embolus, a significant one, as well as the micropulmonary embolus, and that could present as chest pain. Mm-hmm. So COVID is now entering our differential for chest pain quite importantly at the hospital. I'll move on to pneumothorax. So pneumothorax normally presents as a sudden onset of chest pain in a young person, particularly a tall, slim person.
Stop looking at me like that.
Like yourself, James. So I would be, ladies and gentlemen, unlikely to have a pneumothorax. The important thing about pneumothorax or collapsed lung is it's very treatable with a thing called a chest drain. So it's very important to make the diagnosis. And the other reason I wanted to mention it is there are only 3 causes of a sudden onset of chest pain. So pains can come on either gradually, rapidly, or bang, like a bus hitting you. And those 3 are pneumothorax, aortic dissection, and rupture of a major abdominal viscus, such as a peptic ulcer or the esophagus, which I'd now like to move on to. Right, I think we'll move on to the third group of causes, which are GI or gastrointestinal causes. I've already mentioned perforation of a peptic ulcer in the stomach, for example, or the esophagus. That can present as a sudden onset of chest pain. But also we have GORD, G-O-R-D, which stands for gastroesophageal reflux disease. And this is basically when you have a hiatus hernia, and because of a hiatus hernia, acid refluxes back up the esophagus, causes inflammation in the lower esophagus and pain.
That's actually a big one that I see an awful lot at work, people coming in with straightforward reflux. And there was a guy who won a Nobel Prize a few years ago for finding one of the causes of it. As you said, a hiatus hernia is a mechanical problem that's really quite difficult for us to treat. But quite commonly it's due to a bug, H. pylori. And the guy who won the Nobel Prize for it, he thought this bug is causing reflux and causing people to get chest pain like that. He couldn't get anybody to pay attention to it. So he cultured up H. pylori, drank the flasks, caused huge stomach ulceration, which nearly ruptured, didn't quite die, thankfully, proved his point and won a Nobel Prize for it. And that's basically where people such as myself now give out omeprazole and a couple of antibiotics all the while to treat this infection. And what was a killer, because this bug would cause ulcers and could rupture, is now quite run-of-the-mill. To the degree that after Christmas, it may have been just too much good living, I was getting a bit of reflux. And, burden of knowledge, things began to percolate in my head. So I actually tested myself for H. pylori. Thankfully, everything was fine, and it resolved when I stopped basically living on a diet of chips for a week. But, it is something that is a low-level cause that can have a really high-level problem.
There are a couple of other GI causes I think we should always entertain. One is pancreatitis, which is a very nasty disease, sometimes called the internal burn, often due to gallstones, and to something that my mother has, which is surprisingly common, which is esophageal contraction. She seems to have a hyperexcitable esophagus. Sometimes it's called the corkscrew esophagus, and it tightens and causes chest and abdominal pain. And I've done a bit of reading about it before this talk, and apparently it's surprisingly common, particularly in the elderly. Have you seen any patients with that?
I must confess I haven't, but I imagine that getting a barium swallow, where we get the patient to swallow a material that shows up white on an x-ray, I bet that would look quite interesting when she's having that, because we'd probably see that constricted appearance when she had an episode.
So my third group of chest pains are the dreaded other. Now, whenever there's a list of problems in medicine, there's always an other, and the bottom of the other is always lupus or TB or something like that. And sure enough, in other, we have a few of those. I prefer the phrase other than musculoskeletal, which is the traditional way of classifying the other bit of chest pain, because musculoskeletal is only one of the causes of other. What are these other causes? Well, an important one is rib fractures. I've seen that many times, particularly in the elderly, and that may be a presentation of metastasis, so it's an important thing is to investigate rib fractures in the elderly.
And also it can give us a more severe form of what you've already mentioned, our pneumothorax.
Absolutely. So if you have a rib fracture and the sharp bit of the fracture points into the lung, you can have a pneumothorax as well. And certainly you see that in people who've had a road traffic accident. Another cause of chest pain in the other group is trauma. And as an ex-rugby player, you won't be surprised to know a lot of people have trodden on me, and when they tread on you, they damage ribs, they damage muscles, and also you can sprain muscles, and that I think is a cause of musculoskeletal chest pain. A couple of others. One is herpes zoster. So sometimes chest pain can be the presentation of zoster that will come out 2 or 3 days later. Have you ever seen that, James, in your general practice?
Oddly enough, it tends to be more over the winter, and we'll normally have probably 3-4 cases of people who come in, and again, with the history, they'll say they're getting a burning sensation, but it tends to be quite near the surface, and we get them to take off their clothes, and we'll often see this bright red line of vesicles, fluid-filled spots, and that's the shingles, the herpes zoster, come forth for whatever reason, causing that severe pain.
Yeah, and those patients don't tend to come up to hospitals, but I have seen a few patients come in with chest pain and then the rash appears the next day, for example. Another couple of causes before we finish. One is thoracic pain. I've seen this misdiagnosed a few times where somebody has a thoracic spinal problem that presents as chest pain. And I've seen TB missed, particularly in Asian people, which has presented as chest pain. And that's another reason when you have a patient with chest pain and the chest pain's gone on for 4 weeks, you don't know the cause, they look a bit unwell, it's always worth doing a CT or perhaps an MRI. Have you ever seen that in your practice at all?
I haven't seen it in the practice, but when I was a junior doctor, we did have a patient that had spinal TB with another colleague, Ravi Gowda. It was one of the bits that really put him on a pedestal for myself. When you're treating Crohn's, which we'll come to in a moment, you must make sure a patient does not have TB. You've got to do chest x-rays, you've got to do various blood tests before you can give them a medication called anti-TNF, TNF-alpha. The reason being is if you give a patient with TB this medication, you will kill them. Dr. Gowda had a patient who he thought had TB, and he couldn't prove it. He spent weeks and weeks sampling, scanning, x-raying, nothing came back. And he applied to the GMC for permission to give the guy TNF-alpha. He put a loaded gun against his head and fired it. His TB flared, they got a sample, put the antibiotics directly into his spine, saved the guy's life.
That is amazing. Well, as you know, I've also worked with Dr. Gowda, and he's one of my heroes too. And I've had similar patients where he's made an amazing difference to them. And in fact, he's saved their lives. So wherever you are, Ravi, well done. Final cause of chest pain is panic attack! Now, panic attacks are very common. We all have them. I've had them occasionally when I was younger. You may have had one yourself at some point.
I have just, when I think about what I'm going to have to do in the edit.
But anxiety can lead to hyperventilation. Anxiety can also lead to panic attacks. And in my experience, they're more common in men. I don't quite know why. I have this idea that when men get anxious, when men somatise, that means a symptom that is psychological becomes soma is from a Greek or Latin word, Greek word meaning body. And when they somatise their pain, they often somatise their pain to their chest and get chest pain. But I would stress that psychological causes or functional causes of chest pain should only be diagnosed once you know the patient has not had a myocardial infarction, a pulmonary embolism, a dissection, etc., etc. In other words, a panic attack is a diagnosis of exclusion.
And what you say there, I think that we have to make a balance because excess investigations can cause harm, but ruling out all of those big things and having that information to hand and carefully explaining it to the patient can be a hugely powerful treatment in its own right.
And I think it's not wrong for you as a GP to send a particular young person to hospital with chest pain. You're 90% sure it's a functional, it's a psychological problem, but you're not absolutely sure. And it's perfectly reasonable for you to ask us to rule out serious cardiac and respiratory causes. And then when the patient returns to you a week later, you can say to them, you've been to the hospital, you've had the test, you had a TROP-T, a D-dimer, they even did a CT scan and they're all normal. And then it's easier for you to introduce the possibility that a pain may be functional, as we call it.
Well, actually, the lady I mentioned who I caught the PE with last week, she was okay in herself, and that was kind of how we sent her up to the hospital. I explained to her that it looks like a duck, it sounds like a duck, and it's quacking like a duck. But actually, you're quite young, and I know that there's platypuses out there, so I'd like you to go up to the hospital so that they can tell us that actually this isn't a blood clot and I'm just barking up the wrong tree. Unfortunately, it was a blood clot, but we had her in the right place in order to check that.
That's a great story. I feel I've got to come up with another story about somebody with chest pain, and I've just thought of one. A patient I looked after, again, 15 plus years ago, a tall man, such as yourself, James, a slim man, and he presented by driving past our hospital and had a sudden onset of throat and upper chest pain. And a very astute junior doctor examined him carefully and heard a murmur, a rare murmur called aortic regurgitation. And that is due to an abnormal, leaking aortic valve. And when I asked him to present the patient to me, he said he wasn't sure what was wrong with him. He had a feeling there was something going on, but he didn't know what it was. The ECG was nearly normal, but he had this rather odd murmur. I went to see the patient, examine the patient, confirm they had the murmur, and immediately I thought it was a dissection of the aorta. And what happened next was pretty incredible. First of all, the surgeons came to see him, that's the cardiothoracic surgeons. They agreed that it was likely on the history. We did a rapid CT, confirmed the diagnosis, and the patient was in theatre 2 hours later. What was amazing was that after the theatre, the patient came back, had a bleed, went back to theatre, they repaired the bleed, and the patient walked out of hospital 2 weeks later.
And that was with a dissection?
With a dissection.
Wow.
So the diagnosis was really made by a very astute junior doctor who examined the patient carefully.
Nice. Well, I think that's a good point to leave our chest pain journey on. So thank you very much for that, Andy. And you can join us below as we now go on to further C's with Crohn's and celiac disease.